They were discussing kind of bringing some of this information out to the media, and they were like, wait, this is going to let the genie out of the bottle. We may not be able to get this genie back in. There was a study done looking at this phrase, I don't feel like myself. And that phrase was Googled over 5 million times.
That is such a powerful statement, too.
And I hear it every single day. We're seeing a lowering of testosterone levels across the board. When men come in with low testosterone levels, the one thing I'm really looking for is mood and brain. We see men struggle with brain fog, lack of motivation.
Laura, thank you so much for being here today.
Thank you for having me.
Yes.
This is super exciting to get to be on this end of the microphone.
I know, we've switched since the last time we did a podcast together.
Yeah.
So today I'm excited to talk about a topic that I feel like sometimes in the healthcare arena, just it doesn't get the attention that it deserves sometimes.
Absolutely.
Today we're going to talk about hormones.
Yes.
So tell me, when it does come to hormones or hormone replacement, why do you feel like that could be an area that just doesn't really get the attention that it deserves?
Well, I think there's a lot of reasons. I think it did get some attention back in the late 90s, early 2000s with the Women's Health Initiative.
Yeah.
And it got some negative attention around that study. The NIH spent $1 billion on that study. So it wasn't something they wanted to let go of real easily.
For sure.
But the study looked at synthetic versions of hormone therapy. And with that study, they kind of pulled out some data that they misconstrued. They reported absolute risk versus relative risk. They were looking at much older women. They were looking at synthetic versions. Even you'll hear stories about the principal investigator and the group of investigators being in a room, and they were discussing kind of bringing some of this information out to the media, and they were like, wait, this is going to let the genie out of the bottle. We may not be able to get this genie back in.
Oh, wow.
When they were looking at things about breast cancer and heart attack and stroke. And the principal investigator had even been quoted saying earlier that he wanted to put the brakes on hormone therapy. So I think for a long time, hormone therapy has been seen as a negative. But we are seeing a rewriting of this story, with the introduction of, first of all, just going back and looking at that data. And then some of those claims are being restated because these women were much older. It was synthetic versions. So we really are now seeing that come to the forefront. And it was with the writing of a book called Estrogen Matters. We talk about it all the time in our clinic, but it was a breast oncologist that actually, he treated breast cancer for years, and his wife got breast cancer.
Oh, wow. So it's very personal for him, too.
Yeah, absolutely. And she went through treatment, and because of her treatment, was put into menopause. Yeah. And then she was so miserable with her symptoms, she told him, I'm going to take hormones. And he said, absolutely not. You're not. It leads to breast cancer, because he was relying on those older findings. Yes. And
as many people, I think, still do.
Yes, absolutely. And it's a very complex issue. We don't, make light of it at all. Yeah. But we do have to look at the science behind that. And that's exactly what he did. He went back and he looked at that trial. And that's where he saw, these risks were not reported accurately. These were much older women. They had other comorbidities. And he wrote a book called Estrogen Matters. And his name is Dr. Avram Blooming. And so he really kind of got the ball rolling with his book. And then now we just have so many people who have come to the forefront in different specialties, bringing attention to how hormones connect to our other health.
Yeah. Absolutely. So I know in the dermatology world, we get a little bit into hormones just with some of the things that we see. Acne, certainly, we see a lot of hormonal acne, we call it. PCOS is something that comes up, polycystic ovarian syndrome. We see that as a very common occurrence in the dermatology world. What's interesting, though, about PCOS is, so many patients, once we kind of dive into how long have you had it? What were your symptoms? How have you been managing it? It actually will come out that patients will say, well, I haven't officially been diagnosed with it. My doctors just think that I have it.
Right.
Is it difficult to actually diagnose it?
It can be, because it can be it can present different ways.
Yeah.
And then, I worked in a GYN office for about 15 years.
Yes,
so
that's how we got to know each other.
Exactly. But that's how, and I referred a lot of people to you and vice versa. Yeah. But, people would come into the GYN office with irregular periods, and we would be like, you have PCOS. We didn't connect the pieces a lot of times that this is also mean that you probably have low-lying inflammation. You have some insulin resistance. You might have acne, abnormal hair growth, mid-abdominal weight gain. At the root of PCOS is something inflammatory, or insulin resistance. And it can be caused from lots of different things: genetics, environment, our lifestyle. And so it's not just one size fits all.
It's not like you can just check a lab or do an ultrasound and there you go.
Well, we do get some findings on ultrasound. Like we'll see at the string of pearls sign where you have follicles around the edges of the ovaries that lead us to be suspicious for PCOS.
Do you always see that though, even in the presence of PCOS?
No, not always, but you'll see elevated androgen levels. You have to have 2 out of the 3 to get this diagnosis. So elevated testosterone, irregular periods. And so a list of symptoms will then help us to determine, yes, this is PCOS. Gotcha. We look at labs. We look at the pituitary hormones, LH and FSH, and those should be in an appropriate ratio. And when they're not, then we say, this may be PCOS we're looking at. It doesn't really affect whether it is or not. It doesn't really affect how we approach it. We're still looking at insulin levels and testosterone levels and progesterone. And really we find that progesterone is low in those women. And so sometimes if we can come in with some cyclical progesterone, we can normalize periods. We can help them, feel like some of their symptoms are under control and get that ovulation back into a healthier state. There's some supplements we can recommend as well. Yeah. And so we kind of look at it from all different angles: lifestyle, exercise, diet. So those are all helpful when we're looking at trying to control those things that are sometimes really difficult for the patient.
Yeah. So you touched on it for a second, just with fertility. Yeah. So 70 to 80% of women with PCOS, what I read, I believe earlier today, actually. Yeah. It said that they struggle with fertility. Mm-hmm. Why is that the case with PCOS?
Well, you have low levels of progesterone from lack of ovulation. So we just have unhealthy ovulation. So 2 things we have to have for conception is healthy sperm and ovulation and healthy eggs. Yeah. And so when you're not ovulating regularly, then fertility becomes much harder to to achieve.
That makes sense. So in treating PCOS, obviously we love to have the hormonal approach because that seemingly is the best way to get things under control. But for patients that don't want to go that route, that are looking at things like supplements, a natural alternative, what does that look like for you?
So there are some supplements that will target that inflammatory process that's occurring around the ovary. And the best one that I have seen in studies and research would be a combination of myo-inositol and D-chiroinositol. And there's some supplement products by Thorne. It's called Ovarian Care. And then there's another one called Sensitol made by Designs for Health. There's one called Ovasense. These all have the appropriate ratio of the inositol products in them that help to support healthy ovulation and blood sugar stability. So some of the things that we're really trying to manage, and there is a long list of other supplements depending on the symptom that we're trying to manage around.
Very patient specific.
It is very patient specific.
That makes sense.
A good magnesium to restore great sleep, because our hormones are highly impacted by basically 4 or 5 things. There's a prominent urologist I love to listen to, Dr. Kara, and he says you have these 4 pillars of hormone health. They are diet, exercise, sleep, and stress. Whew. And so we all have something.
4 pillars.
Yeah. And I'll add a 5th. I think endocrine disruptors are a huge component that we often overlook just in the products that we use in our, as you know, in our skin, hair, in our homes, our fragrances, detergents, things like that. So we in our clinic recommend that you really look at those things that you're using regularly because they can affect sperm health in men.
Wow.
And just hormone health in general in men and women.
So in the introduction of these GLP-1s, especially for patients with PCOS, metabolic issues, insulin resistance, how have you seen the positive impact of what those have brought to the market?
They get a bad rap in the media sometimes.
They do.
And
I don't understand
there seems to be some negative connotation around the use of them, but in this specific population alone, I have seen such great results because we use metformin a lot for PCOS and insulin resistance, but metformin is not always tolerated.
Absolutely.
And, there's a lot of GI side effects that can go along with metformin. Berberine is another great option that's a supplement that is similar to metformin. And so we see both of those used, but to really, with the effectiveness of the GLP-1s in this population for weight loss and for lowering the insulin levels is significant. And therefore, what we see is some return of ovulation with these patients. So if we can break that vicious cycle of high insulin, low progesterone, no ovulation, I'll give you a case example. I had a patient who had a baby early in her, I think she was in her 20s. She had a child, and then she went about 18 years with little to no period.
Wow.
And had tried to get pregnant for about 18 years. And then she was in her early 40s, had been on a GLP-1, had lost some weight because we, again, restore that insulin sensitivity by lowering those insulin levels. And so it's targeting that insulin resistance. And she was one of our patients. And then she said, you know what? I'm going to try to get pregnant now because my periods have come back after about 18 years of very irregular cycles. So that's yet to be seen whether that happens. But, it restores some of that ability to think and give hope to a population that has really struggled. And we are just fighting these challenges with them. And they're, trying to fix lifestyle, diet, stress, and sleep to kind of target that. So it's just another tool in the toolbox.
Yeah.
It's not a magic bullet, nothing we do for our hormones. There's tools, and so it's a complex, multifactorial issue when we're trying to manage or balance hormones.
I've seen incredible results with patients that have gone down the road with the GLP-1 products and it has seemingly really impacted their lives in a positive way. So I'm sure not for everyone.
Right.
It is something that I think can be very effective too.
It's definitely something you should, or you could consider.
Absolutely.
Given your family history, your personal history.
Yeah.
So it's not all negative. We see really great positive results from these too.
For sure. So let's move a little bit into the perimenopausal group.
Yes.
Talk a little bit about the age group that we're talking about with perimenopause.
Okay. It's probably my favorite group.
Yeah.
I'll just say that because for years I saw women change over the lifespan. Being in a GYN office, seeing women from, age in their teens up into their 70s or 80s, I saw a lot of change happen even before I got there myself. And so I knew that this was a really difficult time for women. And we didn't have a lot of tools or options to offer them. We could tell them, looks like you might be in perimenopause. And they would say, well, what does that mean? What do I do? Well, we didn't really know. We didn't really have the information to give or the encouragement to give. So I saw a lot of frustration. And so for me personally, that is a great age range that I feel like we see great results. But the age that we think about with perimenopause is 45.
Okay.
That most women are there by age 45. Most are there earlier. And I'll say that because the average age of menopause is 51. So we back that up by 10 years.
Okay.
And it really is highly dependent on when your mom went through menopause.
Interesting.
That is the strongest indicator of when you will go through that as well. So, you're getting all of that information when you're being carried in the womb. Wow. And so what your mom does in her pregnancy is affecting your ovarian health. You're born with the amount of eggs you're going to have for your lifetime. And so we get that, genetic code from our mom for how we're going to go through menopause mostly. And so if your mom went through earlier, then you can back that up by 10 years. And that's possibly when you're going to start seeing some perimenopausal changes.
So you're saying the age that your mother was at, less 10 years. Mm-hmm. Wow.
Yeah.
That can be very young.
Yeah. And that's not always the case. It's going to vary depending on lifestyle and some of the other things that, we do, but that's a good indicator as to when you might start to experience perimenopausal changes.
What would those symptoms be?
So there was a study done looking at this phrase, I don't feel like myself. And that phrase was Googled over 5 million times.
That is such a powerful statement too.
And I hear it every single day.
It can be mental. It can be physical. I mean, that can mean a lot of different things.
I've already heard it this morning. My first patient of the morning, I'm listening to her story. And she says, I just don't feel like myself. And so that is my key that we've got to look to see. And I already have some clues based on age and other symptoms. But when I hear that, I'm like, okay, let me tell you about this study that they looked at that phrase. It was Googled over 5 million times, and they correlated that with a list of multiple symptoms. The average age that Googled that was 47.
Okay.
So, I mentioned earlier 45 is oftentimes when we know someone's in perimenopause. I see early 40s a lot in my office with these symptoms. So we know it varies greatly. But there were about 5 areas that they kind of narrowed that down. Like, what does that mean? I don't feel like myself. Well, that's your sleep, brain fog, joint pain and inflammation or body aches, low sex drive, and then usually like mood, anxiety. So we see mood changes. So PMS will worsen. But what's happening in perimenopause is we're seeing progesterone levels fall. So progesterone falls, and that's your mood stabilizer. That's what's helping you feel like all is well in the world. It's considered the happy hormone. It's what helps you get through a good night of sleep and feel like you're rested the next day. So when you hear, I wake up at 2 a.m. or 3 a.m. and I can't get back to sleep, I'm thinking about the emails I need to return, or this child needs to get to this practice, just your to-do list starts. Yes. Then you finally get back to sleep and the alarm goes off. And so then you feel tired and exhausted the next day. So that's perimenopause. And so we see those symptoms, and irregular periods often will follow that. But sometimes we see these symptoms first. And so the progesterone falls. Oftentimes we see testosterone fall as well. But then what's really happening is we are having erratic estrogen levels, and we don't always see that on labs, because if I check your labs when you're having a good month, it'll look normal. Right. And that's why you'll hear, well, your labs look normal.
That is so frustrating. I know that patients get so frustrated with that.
And I've said it to patients.
It feels so discrediting. You know what I mean? It feels like
it's
I'm
like
telling
something's wrong with me.
Right? Yes. It's frustrating because you know yourself better than anyone else, any practitioner is ever going to know you. And it is very frustrating to feel like I have all of these symptoms, but all of my blood work is normal.
Right?
What the heck? Like, there has to be something.
There has to be something. And so I often tell patients, I'm probably not going to see this on your labs right away. We will see it. But this is, from the clinical literature and from these studies, we know this is happening based on your age, based on your symptoms. And that phrase, I don't feel like myself, it helps us as providers to have some confidence in going ahead and offering some options to a patient, knowing that correlates highly with perimenopause.
Yeah. So in thinking through options for these patients, what does that look like? Do you go with hormones? Do you go with natural alternatives? I actually saw a post on your Instagram recently where it said, birth control is not hormone replacement.
Right.
So birth control in this, 30, 40 age range, is that something that's considered for these patients?
Well, it can be.
Or hormone replacement.
Right. So it can be. It's definitely not the same. If you think about a birth control pill and the ingredients in that, it's the synthetic versions of estrogen or progestin, not progesterone. So these are not your natural bioidentical hormones. These are not what our body produces. These are synthetic versions, like similar, not in the same way, but similar to what was studied previously, those synthetic versions. And so it's those, they kind of take over the system. If I check hormone levels, I'm going to see very distinct levels that kind of signal to me that this patient takes a birth control pill. And it's because their natural own hormones are not being portrayed in that lab report. I'm seeing the birth control pill.
Right.
So in this age range, you can still ovulate. So birth control is needed. You can still get pregnant.
Right.
So a lot of times that is offered for birth control, but it is not treating the hormonal concern or the hormonal cause, and so you have to decide, what am I going to do for birth control during this time if needed?
It's such a difficult age range. I mean, aside from the perimenopausal issues, I mean, technically, like you said, you can still get pregnant during perimenopause, even if you're having irregular periods, right? So that is a challenge, because for a long time, even for myself in school, it was a thought of, okay, if you've got a patient that's 35 plus, birth control is not an option for those patients because it's a risk, stroke risk.
Right.
So it is hard to know at that age what to do.
And so you have to think, when I went through school, we had less options for birth control. There are a lot of different options for birth control now, much lower doses. So I often will sometimes transition a woman off of a birth control pill onto hormone replacement therapy. The difference is it is bioidentical, the doses are lower, and it often targets those symptoms that we're really struggling with.
Right.
And it's chemically structured like our own hormones. When we say bioidentical or body identical, those are the same thing, and it's the chemical structure is just like your own. And so it's not made from a synthetic source, and we just tend to respond to those in more positive ways sometimes.
Right.
Plus, then I can see their hormones on labs. I know what's happening at the level of the pituitary or the ovary when I look at hormone levels if we're using bioidentical versions. So in perimenopause, we offer oral progesterone. It's a capsule you take at bedtime. It promotes or stimulates GABA in the brain that helps to promote that calm, deep, restful sleep so you feel restored the next day. You're not waking up at 2 and 3 in the morning. You're getting that good night's sleep. It's great for mood. It's great for anxiety. That happy hormone, it takes the edge off, helps you to feel.
Good night of sleep alone.
I know.
The stress and the mood.
I know. And the best part of my day is when someone texts me and says, "You put me on progesterone. You said it would take 2 weeks to see a result." And that's, I think, a general phrase we all say, right? Take this for 2 weeks and let me know. She said it took 2 nights. And she sent me her sleep score. And it went from 70 to 93.
Wow.
So
it's actually a measurable improvement that
she was like watching her sleep score.
That's amazing.
And she said, "This is what it has done for me. It has really changed my life." So progesterone is powerful, and it's so helpful in perimenopause. The other thing we often do is look at testosterone, because there was a study that looked at minus estrogen and progesterone, just adding testosterone to women. And they did it in the form of a transdermal.
During perimenopause.
Yes, during perimenopause and menopause, I guess. I don't recall the actual age of the patient, but menopausal woman in that transition phase. They looked at 12 indicators for mood, just mood alone. They kind of took out like body composition, weight gain, sex drive.
Right.
They just looked at anxiety, irritability, crying, feeling overwhelmed, all the things that we kind of described during that time. Mm-hmm. And they gave testosterone for 4 months to these women. And then at the end of the end of the 4 months, they looked at those 12 parameters again. They had all improved, every single one of them. Not one had gotten worse. And
That's impressive.
Unfortunately, there's not a lot of studies around testosterone in women. We're getting more. We're looking at testosterone in the brain, how it improves gray matter in the brain, how it improves blood flow to the brain in perimenopause, and then in menopause also. But we're looking, we have a great neuroscientist in this kind of realm of menopause looking at hormones in women's brains. And so she had a study just this year that came out looking at that.
Wow.
So we see all these positives around using both progesterone and testosterone in perimenopause. And then as we get closer to menopause, as we're watching those estradiol levels change, we'll come in and give a small dose of estradiol when it's time. But it's the last one to the party. It's the last one that we add to the picture. Because of those erratic levels, there's months you're going to be making estradiol and it's going to be normal. So we don't want to give you estradiol during that time,
Yeah.
You're making your own. We only want to come in with that when we need to.
That makes sense. Mm-hmm. It's interesting just in the dermatology world, seeing patients when they come in and they are taking testosterone and, they come in and they're struggling with some symptoms that are associated with testosterone use. Increased cystic acne. They'll struggle maybe with some facial hair. Mm-hmm. They're losing hair on their scalp. Mm-hmm. And it's a difficult conversation, honestly, to have with these women because they feel so much better taking the testosterone. And, sometimes those symptoms can only really improve by discontinuing the testosterone or lowering the dose. And that's a really hard conversation to have because it's one of those moments where it's like, well, you kind of have to pick in some ways. What are we wanting to treat?
Right? Absolutely. And I think that's why it's important to have someone who specializes in hormone therapy because there are ways we can dial that down. We can change the form. We can change the dose. We can change the location of where you apply the cream. There's a lot of things we can do to mitigate those symptoms or side effects. And honestly, in my office, I don't see too many, thankfully. If I see anything, it's usually acne. And I often tell patients, I'm wanting to go low and slow with your dosing because there's a sweet spot. There's a place you're going to respond without a side effect, especially in women. Men tend to tolerate these higher doses better and tend to do really well with that. And that's a whole nother subject.
Yes.
But for women, we don't need as much, but we do need some.
A
little helps, it helps with stamina. I explain it's not a superpower. We're not going for super physiological doses or levels. We're going for that stamina that you had before, when we go through this transition and we're exhausted, but we have learned to power through as women.
That's
we're
so true.
Still going to take care of the people around us.
Which I think, honestly, is exactly why I think these symptoms get overlooked, or they just get dismissed as, oh, well, you're busy.
This
or
is
you're
part of
stressed.
life.
It's part
this
of
is
life.
normal.
That's right. You've got a lot going on.
Yes.
And while that all is true, there are these underlying things that are still happening too that there is help for.
Absolutely. And if a patient has testosterone side effects, there are some things we can give in addition to testosterone if we can't figure out a way to lower that dose where they still want to get that, like using spironolactone.
Okay.
For facial hair. We use that irregardless of testosterone sometimes. We use that for just like the peach fuzz that develops on the face and the thinning of the scalp hair. You've helped me with that.
And
that was your topic on my podcast.
Anyone who knows me knows that spironolactone, it's great.
Yeah.
It works and it's effective.
Yes.
I did not realize, though, that taking the spironolactone with the testosterone could be beneficial. In my mind, I always kind of thought it might be canceling out.
Yeah, and it doesn't really, not in a menopausal woman. So it's kind of buffer those side effects, but still give you some benefit with testosterone.
I love that.
And then, acne, can be caused from multiple things. Like I got acne going through menopause and I wasn't even taking testosterone. It's just so like the change of our skin. I was like, what's happening? Yeah. Didn't get it in puberty. So, there's multiple factors, I guess is what I'm saying, around symptoms a lot of times, and teasing that out, working with someone who will spend the time to tease that out and dial in your dose, dial in your labs, give you a precise, prescription plan that's unique to you is so important if you want to live optimally without having to deal with some of these challenges.
Doesn't?
Right. Right.
That's what I love about being able to have, someone like yourself who I can call on with a patient and say, hey, I've got this patient taking testosterone, but they're having some acne, and then being able to have a collaborative approach with a patient.
Absolutely.
That is everything.
Well, and hormones need to be looked at in a collaborative fashion.
Absolutely.
I don't think they have been. In healthcare, we've not done really well at combining specialties.
I agree.
We've siloed healthcare in general, but hormones especially. There's 300 estrogen receptors in a female's body. So it affects everything from their hair to their skin to their teeth, their joints to their heart, brain, bones, and so I follow many, thought leaders in this realm and read lots of information. And so a lot of my information comes from other specialties like orthopedic surgeons and urologists and dermatologists, so it's important that we look in all these specialties and find, the solution for women, because frozen shoulder, for instance, will show up in an orthopedic office. Well, that's often seen in perimenopause. Frozen shoulder, plantar fasciitis.
No way.
Yes. Inflammatory markers go up when we go through menopause. And so we see more arthritis, more inflammation in general. And a lot of times that's a sign that the hormones are falling. So sometimes if we come in and treat from a hormonal perspective, of course, we still have to address the frozen shoulder.
Right.
But hopefully we can kind of buffer that and make that a little bit better outcome in general. But there's a lot of overlap in these specialties, and just getting the education out there and creating some awareness around this is one of our passions.
I love
that. It's one of my passions. It's what I had to do it for myself when I kind of faced some of these changes in my own life. So I'm kind of like walking through this myself too. And then it's what I have to do for my patients, because, we can't silo healthcare. Our bodies are so connected.
Absolutely. In fact, I'll tell my patients, if there's a question and it involves, a question about hormones that I don't know the answer to, I'll tell them, I don't know that I know that answer, but I will find someone who does.
Yeah, exactly.
And, we
Same
work
here
together to get those answers for our patients.
Yes.
And I think that is what makes healthcare strong.
Absolutely.
Certainly it puts the patient at the center of it, as they should be.
And our community strong, it helps create, collaboration. And,
right.
The American Urology Association just came out with some guidelines around vaginal estrogen, for instance. And, you don't think about urology and vaginal estrogen, but with urinary symptoms that we see change in these menopausal years, like leakage or overactive bladder, prolapse, recurrent UTI.
Yeah.
They literally just the week came out with some guidelines.
Wow.
The number one statement that caught my attention was that what we're doing as specialists and in this realm, it should be in shared decision making with our patient. And so
100%.
but that is like the number one guideline. And so whatever you do in your life for your healthcare, shared decision making, find someone who will let you share in that decision, give you the tools you need to educate yourself, and empower you to go make a decision that you're confident with.
I love every part of that because
do too.
I approach it the same exact way with my patients.
Yeah.
It's not my responsibility to tell them what to do.
Right.
I love to present the options and put together different plans and say, here's what's available.
Right.
And they can make decisions that are informed and are based on fact and data and education.
Yes.
And that is, I think that's very important for the patient to be involved.
Absolutely. And then they can leave in peace.
Absolutely, yes.
There's so much confusion in the hormone world. There's so many terms.
Yeah.
First of all, there's different options, different ways to take it. Everyone will have an opinion or an experience that they'll want to share with you. And so then to tease that out and make your own informed decision is important. I brought this book today, Emily, this Estrogen Matters book that I referenced earlier. Every woman in their mid-30s, late 30s, early 40s needs to read this.
Yes.
Or listen to it on Audible. This is going to tell you the story behind hormone therapy and why your grandmother may not have taken that.
I love this because on the very cover, it talks about exactly what my personal concern always has been and, to some degree still currently is around this breast cancer situation. Mm-hmm. So many women, I think, we're going off of this old data, this old information. And when we think about hormone replacement, the first thing that comes to mind is, I don't want breast cancer, so I'm not going to do that.
Right.
So kind of jumping to the menopausal stage. Talk a little bit about, for the women who are seeing these levels of hormones decrease over time, that choose to not have any hormone replacement, what could the negative impacts of that decision look like?
That's a great question. In fact, I often try to remember to tell patients, if you decide against hormone therapy, you're also making a decision.
That's right. And
so first, it's the acute symptoms. We have to, figure out, how are we going to deal with our brain fog or our hot flashes, or vaginal dryness or whatever the case may be. But then we have to think about some long-term health conditions that we often don't see show up until like 10 years past menopause. And then it's not too late, but it's a little more complex.
You don't want to ever feel like you're behind.
Right.
You know what I mean?
You are a little bit behind and the decision is a little bit harder to make because we've lost some of those benefits of hormone therapy. And that would be around your brain, heart, and bones. Estrogen is FDA approved for the prevention of osteoporosis. So osteopenia, osteoporosis prevention, that's one of those musculoskeletal symptoms of menopause that I was referring to earlier, like arthritis and inflammation, where you have the bones, for instance, we have to think about. So then we have, the brain. For years, women were told, hormone replacement may worsen or lead to dementia. Well, that was based on these old trials.
Right.
And again, much older women, different versions. Now there's a neuroscientist that literally came out with a book last year called The Menopausal Brain. And she's looking at the activity of estradiol in the brain. And she developed a tracer to be able to determine the level of estrogen in the brain. And what she found was that when you go through menopause, that 10-year transition time, these receptors get really active. And she said it's as if they're starving for estrogen.
Wow.
And so why is this important? Because there's 2 times the rate of Alzheimer's disease in women. There's 2 times, I believe, the rate of brain tumors, brain inflammation, dementia in women. Women are twice as likely to get some brain disorders. And so she is a neuroscientist, Dr. Lisa Mosconi out of Arizona, who is looking specifically at female brains. And she's dedicated her life to this work. And so she's written these books around estrogen in the brain. So we have to think about our brains. And then we have to think about our heart. Heart disease is the leading cause of death in women, ahead of breast cancer.
Right.
And so, and not to minimize that, breast cancer is a very real concern.
Yeah.
the rates are high, but there's multiple factors around that too. So when we think about heart disease alone, as I mentioned, heart, brain, and bones, that's kind of where we focus as far as the benefit of estrogen. So if we don't take estrogen, then we think about the changes in cholesterol panels, the plaque development in the heart, the arteries around the heart.
Yeah.
And then worsening insulin resistance. When we lose estrogen, we lose the ability to process carbs and sugars as well. We lose some of our insulin sensitivity. So insulin resistance, increased cholesterol, heart disease, all of those become a real concern as we age. And sometimes women don't see this until they're past that 10-year mark. And then they're thinking, oh, maybe I should have, I should have treated earlier.
Yeah.
If we don't treat perimenopause in the perimenopause time frame, then women will come back to us with some comorbidities about 5 to 10 years later.
Wow. That's significant.
Yeah, it is. And so if we don't decide to do hormones, which not every woman decides that, based on other risk factors, family history, personal history, then we've got to really target those areas a little more specifically. And I had one patient say, my doctor said, do you want to be on 10 meds or do you want to take hormones? And I don't use that analogy because that's not always the case, but that is something that we have to think about, as we're making this decision.
Absolutely. And definitely on the front end of it.
Yeah.
Not the reactionary part of
it. Right. Mm-hmm.
So for women who choose to not go the route with hormone replacement, who are looking for things that are more naturally found. Yes.
Yeah.
What do you recommend for those patients? Do you treat really just by the symptoms, or are there things that they can take preventatively?
I asked this question too when I went through menopause. I really did not want to take hormones.
Yes.
That's my personal story.
Yeah.
Excuse me. I really wanted to go the natural route. And I went to a specialist, a hormone specialist, and I asked that question, and she said, Laura, nothing's going to replace your estradiol. So I still didn't do hormones right away. I had to think about it. I had to educate myself. So we work a lot with Nutrition World, and we, promote them in our clinic because we have a lot of the same philosophies. We're not aligned to them business-wise, but we rely on them to be the supplement experts in this area. And they recommend 4 basic supplements for all people, and that would be an omega-3, which is your fish oil, a vitamin D3 with K2 for bones, magnesium glycinate, which helps with mood and I shouldn't say cognition. It helps with mood and sleep and just recovery. There's like 8 different kinds of magnesium, but that one specifically. And then a multivitamin to get those basic minerals that you need. Also, we are big proponents of weight-bearing exercises, getting good quality sleep, lowering your endocrine disruptors, all the things I talked about for hormone health. It's not going to replace your estrogen. You're still going to face some challenges, but can it be done? Yes, people do that and do decide that. So you just have to know that you might be looking at some other comorbidities as you age.
Weighing risk and benefit.
Absolutely.
Sure. It's a tough decision.
It is.
Because I don't know, it's so funny when you think about the decision to take hormone replacement, it feels like such a big, scary decision in many ways. But then at the same time, it's like, especially with these new GLPs that have come out onto the market, most people don't even think twice. You know what I mean? It's like, oh, great. Yes, let's inject
Or a birth control pill.
Or a birth control pill. It's kind of like, yes, let's make that decision and do it. But for whatever reason, with hormone replacement, it feels like such a much bigger decision to make.
It does. And I think it's because of those original trials.
I think you're exactly right.
And then lack of education. And so, we love to get out in the community and talk about, the latest findings in hormone health. In this area, there are new studies coming out all the time.
Yeah.
And so we're seeing, new data around brain health, inflammation, inflammatory markers, autoimmune conditions, things like that we see become more prominent in that transition time.
Yeah. So let's switch gears just a little bit. Let's talk about men.
Okay.
Because with hormones, it's easy, especially as women, to kind of let that be our focus. But hormones affect men too.
Absolutely.
It's actually interesting. I'll see, 15, 16, 17-year-old male patients that come into the office, and we'll be checking routine lab work for whatever reason, that they're on a medication or whatever. And it's funny because they will consistently say, hey, when you check my labs, will you go ahead and tell me my testosterone level too? So it is interesting how the conversation around testosterone with men has evolved over the past 10 years. And there is so much more interest and knowledge, I think, about what the symptoms are and when to start intervening. Talk a little bit about that.
Okay. So men in general have lower testosterone levels now than they did, let's say, a decade ago. We've seen a lowering. They aren't really sure, other than possibly the endocrine disrupting chemicals that we are faced with in our foods and our daily products. And so
that's scary.
It is. It is. And so those are powerful, even just in the plastics, just you think about just what you use every day.
Right.
And so we're seeing a lowering of testosterone levels across the board. And so when men come in with low testosterone levels, the one thing I'm really looking for is mood and brain. Testosterone's a brain hormone. We see men struggle with brain fog, lack of motivation. They say,
what age? What age do you see this starting?
It depends. It's typically in the 40s, late 30s, early 40s. But it's not like a woman. We don't have like a time frame specific. It's decade over decade, you'll see it lowering. And so we've often said it'd be great if we had a baseline to go by in men, like a 25-year-old man to get his testosterone level checked just for a baseline alone would be nice to have, because then we know what to compare that to.
It's interesting because even when you draw a testosterone panel on a male, the normal range is so vast.
It's big.
It is so big.
Yes, 264 to 916 is considered normal.
That's a huge range.
It's a huge range. And so if you have a 300, you're normal, or if you have an 800, you're normal.
Right.
But I can promise you those two do not look the same in a clinic.
You're right.
And so we see the same sort of thing, the brain fog, the lack of motivation, the mid-abdominal weight gain, the difficult with recovery from, like, if you're going to go work out, then you might not recover as well.
Oh, interesting.
You might need more rest. You might need more time to kind of let your body be ready for the next workout kind of thing, And so just being able to have, make executive decisions. We see that change. I have a gentleman that comes to see me, and he wrote me a note and said, or did a little review for me and said, what, I've been able to start a business since starting on testosterone. He said, I could not get off the couch before.
Interesting.
So that's why I say it's a brain hormone in a lot of ways, because we see it impact the ability to make decisions, be motivated, kind of like seize the day sort of thing.
Yeah.
But along with that, we see changes in cholesterol panel. We see insulin resistance worsen with low levels. So the metabolic condition of the man worsens when we have low levels. So we can replace that or we can restore it depending on the age of the man. So like if we had like let's say we had a 28-year-old come in and had low testosterone, which I've seen, and a lot of times it can be lifestyle dependent, like they're not eating the right foods, they're not getting sleep, they're staying up late, maybe, with their friends or playing video games or, all those 4 pillars I talked about, they're not in place, and so they have low levels. But let's say one day they want to have children. Well, then we don't want to give testosterone necessarily.
Why is that?
That can impact fertility.
Okay.
And so, it's not for women, but for men, it will over time kind of turn off those signals in the brain where the body says, oh, I need this testosterone because I can't produce my own.
Yeah, that's very important. I think because there is all of this now interest, I think, in males at a younger age wanting to explore testosterone. And I think that's a very important thing to understand is while in your early 20s, maybe you want to have that increase in testosterone, that can have long-term negative side effects too.
Yes, absolutely. It depends on the length. Everybody is so different in the way your body responds to it, and depending on the length of therapy. But if a man says, I want to have children, then we will offer some options for restorative therapy.
Okay.
Some things we give like clomiphene or HCG that impact directly the LH or the pituitary or the hypothalamus to get those messages to the body to say improve the testosterone.
Gotcha.
And those are very effective for that. And then in that time frame, I always talk to them about let's work on your lifestyle. You don't want to have to be on this for forever. Let's look at ways we can improve your testosterone.
So this is something used for short periods of time?
It could be dependent on genetics, dependent on lifestyle. We'll try to speak to that and impact it in that way. Not always the case. And then if a man says, you know what, I'm in my 40s, I've already had my children, they still may want to approach it from a restorative aspect. But if they are not able to get the results they're looking for or make an improvement, then moving over to testosterone replacement is an option. And that can be done in the form of a cream or an injection, just like for women, but a much higher dose. And so We do that, and we monitor levels regularly, and we see such great improvement in body composition, energy levels, libido, all the things that we see improve in women, we see improve in men.
That's amazing.
Yeah.
I had an interesting situation with a patient one time. I saw this woman, we were treating her acne. She was coming in and it was very, hormonal type acne. And very much like what I would see in someone who is taking testosterone or, whatever. And we kept asking her, are you taking testosterone? She was like, no, I'm not. We checked her levels. She was elevated. All signs pointing to that she was taking it. Long story short, her husband was actually using a testosterone gel.
Yeah, or gel.
And she was touching it. So inadvertently, she was taking testosterone. She just didn't realize
it. And that's a caution we always give to men.
Absolutely, yes.
That if you are going to use a transdermal product like a cream or a gel, you've got to be careful about where you put that and when you use it. Yeah, all those things. Yeah.
So as we sort of wrap this up, so if you could have one take-home message for the people that are listening as it pertains to hormones, what would that be?
I think it's hard to narrow that down to one. Maybe I'll give you three.
I'll take three.
I think for one, we've got to look at the way we live our lives on a daily basis. It's not just a one decision kind of trumps all, but in our lifestyle. That's super important in our foods that we eat, to the exercise we do, to our sleep schedule and our stress loads and that sort of thing. So that's super important for young women. I have a teenager, so I try to get that message across to her, and we try to work on those things. And then as you move through the hormone transition in your life, be man or woman, educate yourself. Look for someone who can provide education to you, or go get that education yourself. And then when it's time to make a decision, you can be confident in that.
Yes.
And so I think educating, therefore empowering yourself, even if you have to find a professional to help you that can give you that shared decision making, is so important. And that would be my message. Whether you do hormones or not is your personal decision. And so, that's never anything that we want to feel pressure someone into making that decision. So it's a personal decision, and we want to support you in that journey, but we want you to know kind of what you're going to be faced with, or what you're faced with now.
I love that. The education part is so important, and for patients to know that they can, come and speak to you and to know that it's not going to immediately end with here's a prescription for some hormones.
Right.
It's a collaborative approach with your patient to formulate a plan that works for them, that gives them the results that they're after, that can have some really positive long-term benefits too.
Yes.
I love what you're doing.
Thank you so much for having me. This has been wonderful. It's great to share this message, to get it out there. The more we can talk about it and talk about our experiences and stories and what we've learned across professional lines and across our patient lines, I think we're going to improve the health of our community overall.
I totally agree. Thank you, Laura.
Thank you.